I hope my slides are visible.
Yes.
Okay.
Yes.
Thank you so much, Dr. Chitra and ARC for this opportunity for allowing me to share an update on Duane syndrome. If you look at Duane syndrome, it's like a puzzle like this. Generally, a strabismus is corrected by correcting the amount of deviation. And if it is paralytic, you might have to look at the abnormal head posture and the limitation, whichever side. But Duane gives us additional problem. It can be either ET or XT. Sometimes even we operate on orthotropic Duane. Sometimes they can have vertical deviation along with that. And all of us know retraction, co-contraction, and overshoot are a part of Duane syndrome. And we also have to consider whether it is unilateral, bilateral, and even the type. It can be one type in one eye, and it can be other type in other eye. And obviously, intraoperative findings like FDT and presence of bands are very, very important. I will just cover out of 10 objectives, I'll be able to cover maybe just 5 objectives. That is types, isotropic, exotropic, overshoot, and a new entity of Duane minus. One thing to note in this objective is that the isotropic Duane is the most common. But in Asia, I think we have almost increasing amounts of exotropic Duane as well. Going to the first objective, I will share some cases to make it a little bit simpler. Electrophysiologically, all of us know it is divided by Huber's into abduction, adduction, and combined deficiency. As you can see in this picture, widening of palpable fissure on abduction and retraction of globe on adduction is a very, very cardinal feature of this patient. They can be orthotropic, as you can see in this picture. They can be exotropic on this gaze, the right gaze, and they can be isotropic on the other gaze. So practically, I think the subtypes isotropic, exotropic, and orthotropic are very important. How do you grade? There is a system of grading by measuring the palpable fissure with the fellow eye. Whether it is 25% less, 50% less, 75% less, or more than 75, we can grade them into grade 1, grade 2, grade 3, grade 4. Same way holds good for retraction as well, the overshoot as well. We can pass a pupillary line in the center, and then how much off it is from the center of this line, we can again grade this overshoot into 1, 2, 3, 4, and even 5. And this way, you can see the preoperative and postoperative and postoperative improvement in the overshoot, because that estimates, unless you have an estimate, you can't really measure the outcome of this surgery. We had a series of 441 patients of this Duane's syndrome. Obviously, the type 1 is the most common. This is almost 15-year-old data. Now we are seeing more and more exotropic, which I'll share in some time. If you see this is a busy table, don't look at everything. Type 1 is the most common, followed by bilateral Duane in our series, and then comes the type 3, and then the least common is type 2. Again, they can have a combination of orthotropia, esotropia, exotropia. Coming to the orthotropic, we see many patients who are orthotropic. What we need to know in terms of their ability, their binocular single vision field may be limited. As you can see, one is the unilateral orthotropic, and this is the bilateral. It's orthotropic only in that position. Otherwise, they have esotropia on either case. What you need to remember is, this is the series what we have published. They have good accommodation, but they have poor convergence and fusional vergence. Stereopsis is noted to be poor in most of these children, in spite of being orthotropia. That's about orthotropic group. Some group, we know that the most common refractive error in patients with Duane syndrome is hypermetropia and maybe astigmatism. That's why it's very important to correct this accommodative component, especially if they're hyperopic. once you correct, you can even correct their abnormal head posture like this just by giving glasses. We should never forget doing a cycloplegic refraction and giving glasses. Coming to the surgery, it can be simpler surgery. If it is esotropia, just do a unilateral or bilateral or asymmetrical medial rectus recession. If it is exotropic duane, do lateral rectus recession. Either it can be unilateral, bilateral, or asymmetrical. Additionally, if you want to improve the outcome of the motility, you can do a full transposition of both the vertical rectus, or you can do a monorectus transposition like SRT as well, along with medial rectus recession. Coming to the second objective, that is the isotropic. In my personal experience, most of the patients with the isotropic duane, they have tight medial rectus, and you have to always assess the severity of co-contraction and isotropian adduction as well. This is very, very important in terms of assessment. This child, as you can see in the upper panel, the central picture has a large esotropia. We did medial rectus recession for that. Additionally, we also transpose the superior rectus to the lateral rectus. You can see abduction also improves. Their abnormal head posture also gets corrected. Similar outcome in these two patients as well. Medial rectus, in this particular patient, we just did superior rectus transposition alone. You can see the abduction improvement, how it improves. The below patient, we had to do both medial rectus and superior rectus. So the simpler mechanism is superior rectus recession, the medial rectus recession. If you want to improve, to get that additional improvement, as we published in this, you will always get this additional improvement in abduction. Without compromising, you will get this additional advantage of improving the abduction in this group. 5 to 10% of them are bilateral. Again, you can do medial rectus recession, as we have done in this case. Since the medial rectus is tight, they can correct their abnormal head posture. As well, you can see a little bit improvement in abduction improvement. So this is what, again, we have published the bilateral medial rectus recession in
60 seconds.
Okay. So I think I can cover only the isotropic part.
Carry on, Dr. Ramesh. You carry on.
Pardon?
You
Okay.
Okay.
This is the publication we are just under revision now. We can also perform this medial rectus and SRT bilaterally. As you can see in this large esotropia in the primary position, it improves significantly even in this group. So here also we can consider doing this. So we did a recent webinar on the worldwide view of this. Still, medial rectus recession alone is the topmost, but people are considering SRT in a significant number of patients. Exotropic Duane, again, it's a very high prevalence somehow happening in the last few years. We are seeing type 1 and type 2 and type 3. Type 3 is the most common exotropic Duane in this group. Again, we have looked at 70 plus patients of the exotropic type Duane. We did a simple lateral rectus recession, either unilateral or bilateral or asymmetrical in this group. So type 3 is the most common needing surgery for exotropic Duane. And we can get good surgical outcome where obtained in various indications. Unilateral or bilateral works very well. But in exotropic, you need to remember that if there is the presence of overshoot, which is more than grade 2, they need lateral rectus Y split as well. This also will come in Jaipur's in the next edition. So this is the simple recession what we have done. In the left, you can see the left exotropia. This is after the recession. One thing to remember is it limits the abduction a little bit more after the surgery. This is the pre and post-operative picture of the same. This is again one more child with the exotropic where we have done the unilateral. This is an abnormal head posture with the exotropic Duane. You can see there is a abduction limitation here as well as adduction. And she also had minimal involvement on the other side. What we did here is we did the recession of the left lateral, and then we did the medial rectus resection. So some indication is there to do a resection as well. So since it was bilateral, we did recession in one eye and medial rectus resection in the other eye. This is the very recent follow-up of the same girl who had surgery almost 9 years ago. She's doing very well over a period of time. So in these cases, I would suggest simple unilateral or bilateral lateral rectus recession works very well. In the absence of severe retraction, you can even do a resection of the medial rectus as well. Yeah, this is again a bilateral where simple lateral rectus recession has been done. So this is the trend. Most of the people do this. I will also talk about periosteal fixation. Dr. Sharma has a very nice paper in IJO. All of you should read for that. This is the overshoot. I will just take maybe 1 more minute and then I will finish it up with this overshoot. You can see Y splitting. If the grade is more than 2, the overshoot grade is more than 2, we'll have to do the Y splitting of the lateral rectus. You can see a pre and post picture. This is what I was talking about. Whenever we are talking about overshoot, it's always associated, most often associated with the exotropic duane. So there is an option. Personally, I would do when there is a severe overshoot, maybe 3, 4 plus, along with the very, very tight lateral rectus. Probably, I think in my hand it works. Dr. Sharma has a typical indication of exodeviation, anomalous posture, improving adduction in exotropic duane, where periosteal fixation along with partial VRT has been tried. This is some of the patient's pictures from the publication of his. You can see a dramatic improvement in the primary position as well as significant improvement in the overshoot. So this is one of the patients we also have done. Instead of partial VRT, we have done the superior rectus transposition to the lateral rectus with the Foster's augmentation with the LR periosteal fixation. This gives a very good outcome, especially the overshoot really reduces significantly. And for overshoot, the trend is still the LR recession and Y split. This is the worldwide trend I'm just sharing with you all. This is the last one. I'll just show this case and I'll stop. Exotropic duane, where you can see they don't have much of a retraction. They don't have much of a limitation, but they will behave very similar to Duane syndrome, as this girl has a left face turn with a small amount of exotropia. What you have done is she had 16 prisms of exotropia. We have done one muscle lateral rectus recession. You can see a significant improvement in the abnormal head posture, but there is a slight exotropia. Maybe because of this slight adduction limitation, it is still there. So this is the pre and post operative. So we just recently published this entity of Duane sign retraction or sign limitation. This could be a possible incomplete forms of Duane retraction, which can happen. We did even imaging of these patients. We can see the absence of 6 nerve in this patient, but they don't have a typical feature of retraction and overshoot. And they do respond very well to the lines of management of Duane syndrome. Just with this summary, I will leave you all. If there are any questions, I will just take. Simple medial rectus recession is effective in unilateral as well as bilateral. But if you add SRT, you would get an additional improvement of alignment. Lateral rectus recession is generally good for exotropic duane. Y splitting is effective, but there are multiple permutations or combinations where just LR split may not be enough. And if some of you want to go through the flow chart of this, this is there published. This is the flow chart of management of Duane syndrome. Thank you very much. I just timed it for 8 minutes. I don't know how come just with the first few slides it came. Thank you very much, Dr. Chitra.
Thank you. Dr. Murli, you have any questions?
Yes, madam.
What are the systemic conditions we need to look for in these patients of Duane's?
Yeah. Yeah. One of the most important thing is everything will be there on the face most of the time. That is, golden hair is number one. And they can have some neck abnormalities. Bilderwang syndrome can be there. They can have a dermoid in on the cornea, and they can have preauricular tags and things like that. That golden hair is the most important. As it is a congenital cranial dyssynervation syndrome, I will also check for hearing and other abnormalities. These are the most important things. There are hundreds of associations, but just for everyone, I think these are the things. When you turn their head, just look at the preauricular tag. I would obviously, the dermoid will be very much clear. I would just always ask in these patients, just check for hearing. It is very, very important.
Thank you.
We have a couple of audience questions.
Yes.
One is, Dr. Ramesh, the superior rectus transposition that you are talking about, is it full tendon or half tendon? Of course, I read your paper, it's full tendon, but have you done any partial tendon transpositions in?
I have done generally full tendon with the Fosters always. I know Dr. Rao in Hyderabad, he always does, and there are many colleagues who does without Foster. They got the same improvement. I always add with the Fosters. It is full transposition.
Is there any demerit of one vertical transposition alone? I mean, any torsional effect, any induced vertical deviation?
Yeah, it is never zero. It is there. Definitely, it can happen. That's one of the fear which will always be there. It is never zero. There are publications. It can happen between 5 to 7% of the patients can still have the torsional problem. There is a paper coming up from Boston's group. They have looked into all the things. It's never zero. It's never zero even in vertical rectus transposition of both the rectus. So it is there. I would not say it's not there.
Is transposition in Duane's equally effective as compared to sixth nerve palsy, or is it less effective? That's the audience question.
Okay, I would think this is my personal experience. I don't have, maybe other panels can share their opinion as well. I think it is more effective in Duane syndrome. I wouldn't say it. We have published the data of sixth nerve palsy also, but I wouldn't say it is not effective in sixth nerve palsy. It is ineffective in very, very severe sixth nerve palsies. If they have -5 or -6, no way we are going to get the full correction. So I will always add that if they have so much, it is not. Otherwise, it's quite good procedure as well. Dr. Sharma or Dr.
Have you attempted
their experience as well?
So have you attempted SRT in case of ExoDRS?
That's what I showed one of the patients. Dr. Sharma does the partial VRT after LR periosteal fixation. My indication, I think his indication also very severe Exotropic Duane. He does not do in all the cases, I think, with the prior discussion I had with him earlier. In these cases, my choice is doing SRT, Dr. Rajesh, along with the periosteal fixation.
Okay.
But the amount or the percentage of Exotropic Duane where I do this periosteal fixation is very, very minuscule. That is important.